Occupational English Test. Listening Test. This test has 3 parts. In each part, you'll hear a number of different extracts. At the start of each extract, you'll hear this sound. You'll have time to read the questions before you hear each extract, and you'll hear each extract once only. Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information that you hear. Now, look at the notes for Extract 1. Extract 1, questions 1 to 12. For questions 1 to 12, complete the notes with a word or short phrase that you hear. You now have 30 seconds to look at the notes.
Doctor, this rash started about a week ago, and it's just been getting worse. It's on my neck, shoulders, all the way to my legs. It itches like crazy, and sometimes it burns. I've also noticed some fluid leaking out in areas like my armpits and behind my knees. I've tried to keep it dry, especially around my abdomen with nystatin powder, which seems to help a bit there.
I understand that must be very uncomfortable for you. Have you noticed any triggers or changes in your environment recently that might have started this?
Not really, except I moved to a basement room a couple of weeks ago. It's a bit damper down there, and I'm using different bedding, but I haven't changed any detergents, so I don't think it's an allergic reaction.
Okay, that's good to know. The basement environment might be contributing to the issue, especially if it's damper. You mentioned using hydrocortisone and terbinafine with little relief. How long did you use these treatments?
I used the hydrocortisone for a few days. It didn't seem to do much, so I stopped. The terbinafine was on and off for a couple of weeks, but again, not much improvement. I've had some relief with antihistamines for the itching at least.
It's good that you found some relief with antihistamines. Since you've been dealing with this for a week and it's progressively worsening, it's important we look closely at both the symptoms and possible underlying causes. Have you had similar issues in the past?
Yes, I've seen several specialists over the years for my skin. I was treated for paniculitis before, and I visited the ER for back pain, but nothing like this rash. This time it feels different. It's more widespread and severe.
Thank you for that information. I understand this has been a particularly challenging time. Let's take a look at your current condition. Based on the examination and your history, the rash seems to be predominantly in moisture-prone areas, which suggests a possible fungal component, but given its severity, there might be more involved. I noticed you also have heat flashes and some fever-like symptoms.
Yes, that's right. I've had these flashes of heat and sometimes feel like I'm running a fever. It's been on and off since the rash got worse.
Those systemic symptoms are important to note as they might indicate an inflammatory process. We've taken some tests today to help us understand what's going on. Your vital signs are stable, but you have a slightly elevated temperature, and your inflammatory markers like CRP and ESR are raised, which aligns with inflammation.
So, what do you think is happening, doctor?
Your clinical presentation, the elevated inflammatory markers, and the dermatoscopic findings suggest a complex inflammatory skin condition, possibly exacerbated by a fungal infection. The exact nature is still to be determined. We're waiting on the fungal culture results, which could provide more insight.
What are the next steps then?
Given the complexity of your symptoms, I recommend a biopsy to better understand the nature of the skin lesions. This will help us tailor a more effective treatment plan. In the meantime, I suggest we start a trial of a stronger topical steroid to manage the inflammation and symptoms. It's also crucial to keep the affected areas clean and dry to prevent further irritation or infection.
When should I expect to see some improvement with the new treatment?
It might take a few days to notice a reduction in inflammation and discomfort. However, if you experience increasing pain, spread of the rash, signs of infection like odor or increased fluid leakage, or persistent fever, you should seek immediate medical attention.
Got it? And the follow-up?
We have you scheduled for a follow-up in 2 weeks to review the progress, assess how you've responded to the steroid cream, and discuss the biopsy results. In the meantime, try to avoid scratching the affected areas to prevent exacerbation.
Thank you, doctor. I hope this new plan can give me some relief.
That's our goal. We'll do everything we can to get you feeling better. If you have any concerns before your follow-up, don't hesitate to contact us.
Extract 2, questions 13 to 24. For questions 13 to 24, complete the notes with a word or short phrase that you hear. You now have 30 seconds to look at the notes.
Doctor, I've been experiencing this chest pain for over a week now. It feels like a burning sensation, almost like heartburn, but it gets worse when it's hot around. The pain comes and goes, lasting about 15 minutes each time. It started just last week, and it's been quite unsettling.
I understand your concern. How frequent are these episodes?
They happen a few times a day. I notice they're more likely to occur in the late afternoon or after I've been outside for a while. With the heat wave we've had, it's been tough.
Have you noticed anything else that triggers the pain or makes it worse, apart from the heat?
Not really, doctor, but I should mention I had a chest cold a few weeks back and was coughing up blood and green mucus. The doctor I saw gave me antibiotics, and thankfully the bleeding stopped, but now this pain has started.
That's good to know. Have you experienced any other symptoms with the chest pain? Any shortness of breath, dizziness, or nausea?
No, nothing like that. Just the pain. I've been trying to take it easy, especially with my diabetes and hypertension. Speaking of which, I've been struggling with my blood sugar levels. They've been higher than usual.
I see. How have you been managing your diabetes recently?
I'm on glargine and aspart. I take 55 units of glargine in the morning and 7 units of aspart at bedtime. But even with that, my fasting sugars have been around 200 to 220 milligrams per deciliter.
That's quite high. We'll need to look into that. Have you made any recent changes to your diet or exercise routine?
I've been trying to lose weight, actually. My doctor advised me to visit a weight management clinic. I've been trying to cut back on my portions and eat healthier, but it's been challenging, especially with my mobility issues. My feet have been hurting a lot, too.
It sounds like you're dealing with quite a bit. How's your mobility in general?
Not great, doctor. I have neuropathy and arthritis in my spine and ribs, which makes moving around painful. I'm also worried about my transportation options if I have to be admitted to the hospital today for this chest pain.
I understand your concerns. We'll definitely take that into consideration. Let's go over your current medications once more to ensure everything is up to date. You mentioned glargine, aspart, lisinopril, gabapentin, fenofibrate, and occasional aspirin and ibuprofen, correct?
Yes, that's right. I also had a reaction to a flu shot once, so I've been cautious about new medications.
That's good to keep in mind. Now, regarding your chest pain, we've done an EKG today, and the results show sinus tachycardia, but no significant ST changes or T-wave inversions. Your chest X-ray was also clear. However, given your symptoms and medical history, I'd like to admit you for further evaluation to rule out any potential cardiac issues and to better manage your uncontrolled diabetes.
I understand, doctor. It's just a lot to handle, between the diabetes, the chest pain, and my other health issues.
Absolutely, and I appreciate how overwhelming this must be. Here's what we'll do. We'll perform some additional tests to ensure there aren't any clots or other lung issues. We'll also have a diabetes specialist see you to adjust your medications and management plan.
Thank you, doctor. I just want to feel better and manage these health problems more effectively.
Of course, that's our goal as well. I'll make sure the team is aware of your situation and that we provide the care you need. We'll also update your contact information and make sure transportation and other logistics are arranged for you. I'll be following up on your status regularly while you're here.
Thank you, doctor. I appreciate your help.
You're welcome. Let's get you started on those tests and get you the help you need. If you have any questions or need anything at all, please let me or the nurses know.
That is the end of Part A. Now look at Part B. Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25.
Preventing pressure ulcers is an essential part of caring for bedridden or immobile patients. These ulcers, also known as bed sores, can lead to severe infections and other complications if not managed properly.
I see. What are the main steps I can take to prevent them?
First, it's crucial to reposition the patient every 2 hours to relieve pressure on the skin. This might mean helping them turn from their back to their side and then to their other side.
What about their bedding and sitting positions?
Use supportive surfaces such as specialized mattresses or cushioning that reduce pressure. For sitting, ensure that they change positions frequently and use cushioned support.
How do I care for their skin?
Keep the skin clean and dry to prevent irritation and breakdown. Check regularly for redness or sore spots, especially in areas where bones are close to the skin, like hips, elbows, and heels.
And nutrition?
Ensure their nutrition is adequate, as malnutrition can make the skin more vulnerable to damage and slow the healing process. Include plenty of proteins, vitamins, and minerals in their diet.
Now look at question 26.
Today, I'll detail a case of patient confidentiality breach that occurred recently in our facility. This incident involved the accidental sharing of sensitive patient information via email to an unauthorized external consultant.
That sounds serious. How did that happen?
The staff member involved failed to double-check the email recipient and attach patient details meant for internal review. This was a clear violation of our data protection policies.
What actions were taken following this breach?
The breach resulted in a formal investigation. The staff member was reprimanded and underwent retraining on data security and privacy policies. We also reviewed and tightened our email protocols and security measures.
How can we prevent such incidents in the future?
It's crucial to enforce strict protocols for handling patient information. Regular training sessions on data protection must be held. Moreover, implementing more secure technologies and routine audits of our processes will help minimize these risks.
Now look at question 27.
Patient-reported outcome measures, or PROMs, are increasingly vital in our clinical assessments. They offer insights directly from the patients about their health status and the effectiveness of treatments.
Indeed, patients' perspectives are crucial. How can we better integrate PROMs into our routine clinical practice?
Training our healthcare team on the importance and utilization of PROMs is a start. We also need to incorporate user-friendly digital tools that facilitate the collection and analysis of this data.
I agree. What about the challenges in using PROMs effectively?
One major challenge is ensuring that the data collected is accurate and reliable. We need to design questions that are easy for patients to understand and respond to. Additionally, integrating this data into clinical decision-making processes is essential to make it actionable.
Yes, making the data part of the patient's ongoing care plan is crucial. It could really transform how we tailor treatments to individual needs.
Now look at question 28.
This newborn, born prematurely at 32 weeks, is currently stable but remains in the NICU for monitoring. He's been on CPAP since birth to aid his breathing.
Understood. What's the status of his feeding and growth?
He's being fed via a tube with expressed breast milk, which is supplemented to meet his nutritional needs. His weight gain has been steady, which is a good sign of his development.
Any specific concerns or complications during my shift?
You should monitor his breathing closely, check for any signs of respiratory distress, and ensure that the CPAP machine settings are adjusted correctly. Also, keep an eye on his temperature and watch for any signs of infection.
Will do. How about his overall prognosis?
His prognosis is good, but he needs careful monitoring and support. Tomorrow, he is scheduled for a routine screening for retinopathy of prematurity, which is critical for early detection and management.
Now look at question 29.
I've been experiencing chronic back pain, and I'm interested in exploring acupuncture alongside my current treatments. What are your thoughts on integrating it?
Acupuncture can be a great complement to conventional pain management strategies. It has been shown to reduce pain levels significantly for many patients without the side effects associated with some pharmaceuticals.
How does acupuncture work?
Acupuncture involves inserting very fine needles into specific points on the body to stimulate nerves and muscles, enhancing blood flow, and triggering the body's natural painkillers.
And how often would I need these sessions?
We typically start with once or twice a week sessions, then adjust based on how your pain improves. Each session lasts about 30 minutes, and you might start to notice improvements after just a few sessions.
That sounds promising. Let's include acupuncture in my treatment plan and see how it goes.
Now look at question 30.
Today we'll focus on recognizing and responding to signs of elder abuse, which is a critical issue in healthcare settings. Elder abuse can manifest in various forms, including physical, emotional, and financial.
What specific signs should we be on the lookout for?
Physical signs may include unexplained bruises, cuts, or injuries. Emotional abuse signs could be the elder appearing withdrawn, scared, or depressed. Financial abuse might show up as sudden changes in their financial situation.
How should we handle a suspicion of abuse?
It's vital to follow our hospital's protocols. Immediately report your suspicions to the designated authority in our facility. Make detailed notes about what you observed and ensure that the elder is safe from immediate harm.
Is there additional support for staff in handling these cases?
Yes, our hospital offers training and support for staff dealing with these complex situations. It's important to approach these cases with sensitivity and a commitment to the safety and dignity of the elder involved.
That is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear two different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1.
Welcome everyone to our educational webinar on adrenal insufficiency, a crucial and often under-recognized endocrine disorder. Today we'll dive deep into the complexities of diagnosing and managing this condition with a special focus on iatrogenic causes, which are particularly relevant given the widespread use of glucocorticoids in various treatments. Let's start with a case study that illustrates some of the key challenges and considerations in adrenal insufficiency. A 54-year-old female patient, previously healthy, presented to the emergency department with profound fatigue, abdominal pain, and marked hypotension. She reported a history of asthma, for which she had been taking prednisone intermittently, most recently for a severe exacerbation about a month ago. She was not on any steroid medication at the time of presentation. Initial laboratory tests revealed hyponatremia and hyperkalemia, prompting an endocrinological consultation. A random serum cortisol was found to be low at 3 micrograms per deciliters, and an ACTH adrenocorticotropic hormone test showed elevated levels, suggesting primary adrenal insufficiency. Further questioning revealed that the patient's use of systemic glucocorticoids had been quite frequent over the past year, varying in dose and duration, complicating the clinical picture with potential secondary adrenal suppression. This case underscores the critical importance of considering a detailed drug history in patients presenting with nonspecific symptoms like fatigue and electrolyte imbalances, particularly in those with a history of steroid use for chronic conditions. Now let's delve into the mechanisms of adrenal insufficiency. The adrenal glands are responsible for producing glucocorticoids, mineralocorticoids, and androgens. In primary adrenal insufficiency, also known as Addison's disease, the adrenal glands themselves are dysfunctional. This can be due to autoimmune destruction, infections, or, as in our case, potentially compounded by chronic exogenous steroid use, leading to atrophy of the adrenal cortex. In secondary adrenal insufficiency, the problem lies not in the adrenal glands but in the pituitary gland, which fails to produce adequate ACTH. This can be due to pituitary tumors, surgery, radiation, or suppression by exogenous steroids. Understanding the underlying cause is crucial for appropriate management. Diagnosis typically involves an ACTH stimulation test to assess the adrenal response. In our patient, the rapid ACTH stimulation test confirmed adrenal insufficiency with inadequate cortisol response, reinforcing the diagnosis. Management of adrenal insufficiency must be swift and accurate. In acute crises, immediate administration of hydrocortisone is life-saving. For chronic management, replacement therapy with glucocorticoids, and in cases of primary adrenal insufficiency, mineralocorticoids is necessary. An essential component of managing these patients is educating them about sick day rules, which involves adjusting glucocorticoid doses during periods of stress or illness to prevent adrenal crisis. Patients should also wear medical alert bracelets and carry steroid emergency cards. Monitoring in adrenal insufficiency includes regular assessment of electrolytes, renal function, and glucose levels, as well as periodic reassessment of cortisol levels to adjust therapy. Bone density monitoring is also important due to the risk of osteoporosis with chronic glucocorticoid use. Now transitioning to iatrogenic adrenal insufficiency, which our case hints at, it's imperative to recognize the risk associated with the cessation of long-term glucocorticoid therapy. Patients often undergo what is known as a steroid taper, but the adrenal axis may not recover immediately, and patients can remain at risk for adrenal insufficiency for months after stopping steroids. In terms of prevention, whenever prescribing steroids, one must consider the least effective dose for the shortest duration and always contemplate the necessity of tapering off, especially if the treatment exceeds 2 weeks. Adrenal insufficiency is a multifaceted disorder with various etiologies, requiring a high degree of clinical suspicion, especially in patients with a history of extensive glucocorticoid use. Effective management not only involves immediate and adequate hormonal replacement, but also comprehensive patient education to prevent potentially fatal adrenal crises.
Now look at Extract 2. Extract 2, questions 37 to 42. You now have 90 seconds to read questions 37 to 42.
Hello everyone, and welcome to today's healthcare seminar. We're focusing on the management of stress-induced hyperglycemia in hospitalized patients, a complex but critical aspect of medical care that has significant implications for patient outcomes. I'm Dr. Eleanor Reed, and I have over 15 years of experience in endocrinology and diabetes management. Today, I'll guide you through understanding this condition, its implications, and the most effective treatment strategies, underpinned by recent research and a relevant case study. Stress-induced hyperglycemia is commonly observed in patients who are critically ill, regardless of whether they have a prior diagnosis of diabetes. The physiological stress of illness, trauma, or surgery can trigger an increase in blood glucose levels due to a surge in stress hormones like cortisol and epinephrine. These hormones antagonize insulin action and increase hepatic glucose production, complicating the clinical picture of patients who are already vulnerable. Studies from Harvard Medical School have illustrated that stress-induced hyperglycemia, if not adequately managed, is associated with a higher incidence of adverse outcomes, including infections, prolonged hospital stay, and even increased mortality. Therefore, understanding and managing this hyperglycemia effectively is crucial for improving patient care and outcomes. A pertinent case study involves a 58-year-old male patient, Mr. Thompson, who was admitted to the hospital following a severe myocardial infarction. Mr. Thompson did not have a history of diabetes. However, upon admission, his blood glucose levels were elevated, registering at 180 milligrams per deciliter. This scenario is not uncommon in acute myocardial infarctions where the stress response significantly elevates glucose levels. Initial management for Mr. Thompson involved stabilizing his cardiac condition, but his hyperglycemia needed concurrent attention. The first step in managing such a patient is distinguishing stress-induced hyperglycemia from undiagnosed diabetes, which involves reviewing the patient's medical history, current medications, and conducting an A1C test. Mr. Thompson's A1C on admission was 5.9%, which supported the diagnosis of stress-induced rather than chronic hyperglycemia. Management strategies, as recommended by recent clinical guidelines, include careful monitoring of blood glucose levels and the judicious use of insulin therapy. In Mr. Thompson's case, insulin was administered to manage his glucose levels acutely. It is important to avoid overtreatment, as hypoglycemia can exacerbate outcomes and lead to further complications. The goal is to maintain blood glucose levels in a safe range, typically between 140 mg per liter and 180 mg per liter, according to guidelines from the American Diabetes Association. For ongoing management, it's crucial to continually reassess the patient's glucose handling as their clinical condition stabilizes. As Mr. Thompson's cardiac condition improved, his glucose levels began to normalize, indicating the transient nature of his hyperglycemia. It's also essential to consider the educational needs of patients and their families regarding the potential for stress-induced hyperglycemia and its implications. Education can empower patients to recognize and address potential signs of hyperglycemia early in the course of future illnesses. Long-term follow-up in such cases might include reassessment of glucose metabolism after recovery, as stress-induced hyperglycemia can sometimes unmask underlying glucose intolerance that had not previously manifested clinically. The management of stress-induced hyperglycemia should be a tailored approach that considers the underlying cause, the severity of hyperglycemia, and the patient's overall clinical condition. Effective management not only addresses the immediate risks associated with high blood glucose levels, but also impacts long-term outcomes. By focusing on interdisciplinary care and individualized treatment plans, healthcare providers can significantly improve the prognosis and quality of life for patients experiencing this complex condition.